And our last page over here is our dispo page. So dispo will start off with clinical impression, and this was just put in by a previous chart that was opened by one of our test physicians over here. But this would be blank to start off, and as soon as you get to this page, it'll automatically highlight clinical impression. And as soon as you try to click away from it or go back to one of the other pages, if you were just jumping into the dispo page sometime in the middle of your chart, it'll say clinical impression needed. If you need to get away from that, just click OK and cancel, and that'll let you navigate back through the rest of your chart. So now that you're ready to document your clinical impression, you go to Add Impressions on the bottom right and start typing in any of the impressions that you'd like to add in here. Just find it, click on it, and it'll add it into the top over here. And if you rule something out, so now we have our primary. You would select that over here and then check this box for ruled out. So now we ruled this one out. And if you need to unselect or delete one of the clinical impressions up here, then just uncheck it in this checkbox up here and it'll take it away. And you click OK and that'll put them all in there. One last thing to point out over here, if you do type something in and it's not an impression that is in there, and it's not a pre-selected or pre-made impression, then you can just enter as free text and it'll put it up here as free text without an ICD code. So those are the different ways that you can add in clinical impressions.
And I will open this up to the group. Obviously, you'll see that you can only click primary, I believe, on one option. You can click rule out, I believe, on multiple. So this always becomes an issue and again, from a billing standpoint, we want to make sure probably that we've always tried to put down multiple things, ruled out X and Y, but the diagnosis is chest pain, that we choose our primary diagnosis wisely. If somebody comes in with shortness of breath, for whatever reason, and it turns out that it's anxiety, my recommendation would be, again, their chief complaint and the thing we were most concerned about was shortness of breath or dyspnea. So I put that as your primary diagnosis. And then all your other diagnoses will still follow, which could be anxiety reaction and so on. But you want to paint that picture of what that person came in. So a motor vehicle accident, that could be your diagnosis concern for a motor vehicle accident. And then you could also say he had a contusion to his left arm, he had, a laceration, whatever it is. But choosing that primary diagnosis wisely, it can make a difference in that when it comes to billing. So I would just make sure you choose that one, that the most encompassing and probably the most severe initial concern you had for that patient.
Okay. And the next line we have over here is disposition. So disposition, you can say disposition home yes. And this yes over here is what will change the tracker to say that the disposition DIS-D for discharged home. And the admitted also has a yes over here, but this is not where that would change the tracker. That would be under the consultants and the reeval MDM under the admit accepts. A few other dispositions here that you can select. This is the only one that will change the tracker for all of these, and then transfers at the bottom that will change the tracker as well, but we'll get to that. And then disposition time, this is what will stop your clock for dashboard and all those times. So you can click now if you're doing this in live, or back time it if you're finishing up your chart later. Disposition date, just click today on all of those. It's going to be mostly today for all these ER patients, but just a quick today will help out. And then vital signs, we'll review the same vital signs that we saw on that first line in the physical exam page. It'll have the first documented, last documented, just to quickly review them again. And you can get rid of this half page again by just clicking OK or cancel, and take you back to all the menus underneath. So all prior vital signs reviewed, yes. Condition, you can put in your condition here. So prescriptions, these prescriptions are just for documentation purposes. These aren't going to print out for the patient or onto the patient's discharge instructions. So these are just for your documentation purposes, or to quickly be able to view what prescriptions were given for this patient if you or the next provider are quickly looking at this old note to see what they were discharged with, since the discharge program is separate somewhat from Meditech. So just a quick prescribed Zofran and whatever will just flag the next person to see that that's what you discharged them with. Counseled patient, this will be a quick way to just document a quick reevaluation essentially, but those are all documented in re-eval. Just counseled the patient on all of these, need for follow-up when return to ER. Against medical advice, if your patient leaves AMA, you can go into here and do all the clicks under these submenus and have that reflect the discussion for AMA. You can also free type things in this final AMA note. This will pre-populate a paragraph that you can change to specify what happened, or this is just a text box that you can add in free text over here to give more detail to why the patient is leaving AMA or what happened in that discussion. And then you click OK to save that in there, but make sure that if you do click on this while clicking down, that if this pops up, if you click OK, that's importing the note into there, so you want to click cancel and say yes to cancel without saving changes, and that won't save all the paragraph and all of your notes into there. So if you're just accidentally clicking through it, make sure you click cancel. If you mean to save it, then click OK, and that is AMA. And then transfer of care, this is if you're signing out the patient to the next provider. So this is at facilities where you might sign out a couple of patients to the next provider if this is the end of your shift. You don't want to change the provider's name on the tracker. You need to leave your name on the tracker as is, and they don't need to click sign up or anything like that. But you, as the first provider, would go into here and click on care transfer to and find the next provider's name. Select that provider, OK, next, and select the time that we're transferring care to this provider, and that'll basically document that we're transferring care to this next provider at this time.
Okay. Can I just ask a question? You guys talked about care transferred not to another facility, but from another provider. So Dr. Brokish was working on this patient. He now transfers the patient over to me, puts my name in, puts that time. Now I want to document on that patient. I don't want to mess up any of the initial greet time. How do I, as that provider, now document on that patient?
So basically what you would do is there's a couple different things that we'll go into. One is that I'll put you as a co-signer on there, one, and the second thing is that you would just basically double click on my name and then just backspace out and put your name, your mnemonic in.
So again, the key being though, just like when we signed up for a patient that our mid-level had gone, we're still going to double click in that same area, pretty much sign ourselves up. Right. One place we want to stay away from, again, in this case, is that sign up button at the top right, because that is going to change the initial greet time. Is that correct?
That's our understanding. We're still trying to figure out the whole sign up thing in terms of transfer care, but just to be on the safe side, just click on my name and then change it to yours, and that way we know for sure it's not going to change that scene time.
And then the next line is supervising physician note. So this is another big blank text box. So this is where you would add in your attestations for the scribe if you're using a scribe or a mid-level, and the scribes will be able to do this for you as well. But you would just be clicked in this text box and click on text on the top right over here and find the addendum that you are adding in. So the ones that are made for our providers are all called attest ED, and you would select the one that is appropriate for your mid-level and your scribe, insert them, and the scribes will do this as well for all their patients. But this says that I saw and evaluate the patient and agree with the mid-level note, except as noted, and then the scribes will put in their name and their information here for seeing the patient with you and documenting under you. And they would just click OK, and this would be done on every patient that you see with a mid-level or every patient that a scribe charts on with you. And the last couple of things down here, transfer. So if you are transferring the patient out, put in the transfer request time and transfer request date. And then if you do have a call and all of that, then you can put call return time, spoke with, where the receiving hospital or facility is that transferred was accepted, and all the additional details here. So the two things that will flag the tracker to say DIST for transfer are the transfer request call time and the transfer accepted yes. So those two will change the tracker to say that T for transfer and flag everybody to know that this patient is ready for transfer or has been transferred.
And the one interesting component about this that is a little bit different is that the call time, the transfer request time, actually is the one that stops the clock for your turnaround time. So it gets a little bit fuzzy in terms of if you're talking to Green Oaks or MHMR and they come out and see the patient and say, oh no, they can go home. Well, was their disposition 30 minutes into their care or 5 hours once they came or whatnot? But again, if you know that this person needs to be transferred, even say like a pediatric facility or whatnot, and you know that they're going to need to get admitted, the time that you talk to your charge nurse or HUC or whoever it may be to get the call center, that is the time that the transfer request was made and stops the clock on your end for your turnaround time.
All right, and the last thing on here is critical care. So critical care first line is for the time that you're giving critical care for, and the second line just the details of that critical care. And if you do want to give more details than all these pre-selected or pre-written boxes, you can just click on any of these or the dotted line or comment on any of them and add in additional details for the critical care.
Now for the way that Meditech makes this look is unless you are the only one documenting on the chart, meaning that you don't have a scribe, you don't have a PA, that you actually want to put patient management by me and then Dr. Peter Brokish. So you'd actually type in here Dr. Peter Brokish, because like I said, the way it kind of makes it look is that critical care time management by me, if a scribe or a PA, it's extremely unclear in Meditech what this 30 to 74 minutes is. So most of the time I'll just do this by Dr. Peter Brokish and then I'll just click these right here and then call it a day and say there was my 30 minutes of critical care time, but by me, Dr. Peter Brokish.
I think Peter brings up a good point. This is a point of current concern, the concept being critical care in a shared service. So if you have a mid-level with you, the question really becomes when there's this statement, this patient managed by me, auditors can look and say, well, who is me? Is this the mid-level who did it? Is this the doctor who did it? Is this the scribe who did it? So this, it is, when you actually look at the chart, it is actually under the doctor's name technically, but I agree 100% with Dr. Brokish that this is a wonderful way to take any confusion out of it. So document 30 to 40, whatever the time is, and then the second area of critical care, the second box, once you go down to the second box, the second box here, obviously this will pop up, patient managed by me, and then the comment as done. You can see the little balloon next to it that's having that takes all of the confusion out of it. I'll add just a couple other things onto this. Again, just to really hit home a couple points. One, this prescription stuff, it can make a difference. Unfortunately, right now, as was stated, our discharge 1, 2, 3 is not linked to our chart. So we don't know necessarily if prescription drug management was given. Prescription drug management can add to severity and risk of your case. So again, writing in a short line of what was given, Zofran, Norco is good. And the other reason, as Nasser hit on, is probably even more important is if another provider is looking at your chart from a day ago or 5 days ago or a week ago and want to see what you gave, somebody had a urinary tract infection, is coming back in with similar symptoms, well, were they given antibiotics? And you leave this blank, it's hard to know what was given unless you actually go through a bunch of other steps. So this actually makes it much easier for your colleagues to see what you've done. This condition button here can tie directly related to your critical care. If you're saying this patient, you go here, stable, Again, you could argue that now the patient is stable, but if this patient is going to the ICU or something like that, you probably don't want to use that button. You probably want to say this patient is critical or guarded. And the last note I will make is, again, these attestations are very important and run the gamut of different things that you can add in. Some of our facilities have residents that you use. There's the resident specific attestation. There is patient left before I could see them attestation. The last thing I would add is this is another wonderful area if you did not specifically document in the chart. Again, you can use that caveat or that attestation I saw and evaluate the patient, agree with mid-level notice, except as noted below, and write your short, brief synopsis. Patient came in for abdominal pain, abdomen at time of my exam, soft, non-tender, non-distended, blood work, CT, no acute process, pain at discharge, 0 out of 10, discharge home to follow up with primary. And that really shows that you saw the patient, you examined the patient, and you were comfortable sending that patient home. This is a wonderful area that you can free text in, 2 or 3 lines, and you're pretty much done and don't necessarily even have to go into the chart. Again, now with scribes, lots of times there's going to be plenty of documentation, but if you do not have a scribe and the patient was seen by the mid-level and you agreed with everything or accept a couple things, a perfect area to be able to write that information in.